This is the University of Otago.
No mai haere mai, ko Richard Blakey ahau, ko hokanui te manga, ko mataura ta awa, hei ka mahi aha ta wharewananga o Otago. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Good evening, everyone. My name is Richard Blakey. I'm the Deputy Vice-Chancellor for Research at Enterprise at the University of Otago, and it's my great pleasure to welcome you here to a celebration of one of our new professors, Professor Alison Heather, who's going to give her inaugural professorial lecture tonight. It's a great pleasure at these occasions to welcome members of the university and members of the general public to share with us the experience and the research and the story of what has come to lead Professor Heather to be a member of our academic staff and to join the ranks of our leading professors. Attaining the position of professor at the University of Otago is no mean feat, and we'd like to celebrate this and share that with a wide community, both within and outside the university. It is a very high honour, and we do expect extremely high standards here at the University of Otago, that achieving at the highest level in all aspects of the role is expected in teaching, in research and in service, and both those that we promote from within and those that we appoint from outside are expected to have those qualities when they come to us and maintain and retain those qualities through their career with us. We are also like to pride ourselves on being a very family-friendly university that encourage people to have a very strong work-life balance. So we welcome Regan, Professor Heather's daughter, here tonight, and other members of her family and community who might be joining us in person or through the broadcast of this. And also, I will highlight to you, and I'm sure others will do, that Alison is a very special person in undertaking a lot of high-level activity outside of her role. She's a very accomplished sportswoman who achieves at a high level in a lot of multi-sport activities, and I'm sure that will be highlighted by others. Just in terms of the ceremonials here, we have a very interesting structure at the university, very hierarchical and traditional in some ways, and here that hierarchy is represented at all levels. At the university level, at the divisional level, we'll have our Pro-Vice-Chancellor in the Division of Health Sciences talking. That divisional structure has schools and departments. We have the Dean of the Otago School of Medical Sciences, in which the Department of Physiology sits, and also the Head of Department in the Department of Physiology who will talk to you. So we'll have a little bit of theatre in presenting and introducing the speaker to you. The speaker will speak, and then we'll do the summaries and wrap-ups before we invite you for some refreshments in our staff club. So with that, I will hand over for the next phase of this to Professor Associate Professor Pat Cragg, the Acting Dean in the Otago School of Medical Sciences, to introduce the speaker.
Well, it's a great pleasure to be able to introduce Alison. As Richard has said, she's new to the university, and so this is an ideal opportunity for you to meet her. Many times our professors are promoted from within, and so they're already known. So Alison's new to the university, new to you, and doing this so early, because she only arrived in January, is an ideal opportunity for everyone to find out who she is and what she does. So my role is to give you a little bit of background about what she's done on her journey to becoming a professor at this prestigious university. And she achieved her BSc Honours First Class at the University of Sydney in 1991. And she then embarked on a PhD in microbiology, completing that in 1995. And from that PhD, she achieved at least 3 publications, and it was on bacterial genetics, which was her focus in her microbiology PhD. She was then appointed as a postdoctoral fellow in the Department of Endocrinology at the Royal Prince Albert Hospital in Sydney, and she held that position between 1996 and 1999. And there she switched her interests from bacterial genetics to diabetes and the kidney complications that are associated with diabetes. And I suspect that in her talk she will give you some indication of why she did that switch. And that was a successful postdoctoral fellowship. She did a very prestigious book chapter and 3 publications. And that led to her being appointed as the inaugural Diabetes and Endocrinology Research Fellow in the Department of Medicine at the University of Sydney. And there she initiated her own independent research program studying the influence of sex hormones on the major heart disease atherosclerosis. And you can see that from what's up above me that she's staying with the sex hormones and gender aspect still. And in establishing her own independent research program, she obviously started off gaining first small grants, and she was gaining them from Diabetes Australia, the Leo and Jenny Cancer Foundation, and that enabled her to move on to larger grants from Merck, NHMRC and the National Heart Foundation. And that was a very successful research fellow position. She gained at least 8 publications there, to then become the group leader in the Heart Research Institute in Newtown. And there she switched to sort of high-density lipoproteins and their ability to protect against atherosclerosis. And she also got into the area of detection of designer drugs in sports doping. She held that position up until arriving here, but it overlapped starting in 2009 with gaining a senior lecturer position in the School of Medicine and Molecular Bioscience at the University of Technology in Sydney. And she was promoted to associate professor in 2013. So over that period from 2004 onwards, the number of her publications rose rapidly, and so 31 more publications, 1 more book chapter, and gaining larger and larger grants, and also a lot of funding from the Anti-Doping Research Panel and the World Anti-Doping Agency. During the course of all that research, she was also supervising a large number of students. So since 1999, she supervised 14 PhD students, 3 master's students, 8 honours students, 1 postgraduate diploma, and has supervised 7 research staff ranging from research assistants to postdoctoral fellows. And they've obviously been integral to her research program, as her success and her publications. She's not only been focused on research. Once she was appointed as a senior lecturer, she was then able to teach, and she's done a wide range of teaching activities, both within the sciences and within the medical courses. And she's served on a number of committees, such as the Executive Committee for the Honours Programme. She's acted as the Postgraduate Student Coordinator, and so on and so on. She's also been interested in biosafety, so she's served on a biosafety committee. She's also been very interested in her research is on animal models, as well as some research on humans. And so for a while, she was deputy chair of the Animal Ethics Committee. And she does quite a lot of research grant reviewing, an editor for the Australian Atherosclerosis Society, and has organised a number of conferences. So, as Richard has said, gaining an appointment as a professor at this university requires that you come with all the elements of research, teaching and service, and you don't necessarily put them in that order, but Alison has shown that she can cover off all those different aspects. So it gives me great pleasure to invite Alison to talk to us about the research that's dearest to her heart. So welcome, Alison.
So in my research career, I've focused on the heart. The reason is everyone has one. From the moment it starts beating until the moment it stops, it works tirelessly. And during an average lifetime, it will beat greater than 2.5 billion times without ever pausing to rest. So it may surprise you that the actual shape of the heart looks nothing like what is depicted on a Valentine's card, but instead it's an odd-looking structure that would actually fit in the size of your fist. And the primary function of the heart is to work as a pump. So because it's a pump, it has a high level of muscular tissue, and this muscular tissue contracts just like your skeletal muscle to push blood around our body. So in overlaying or under the muscle tissue overlays 4 empty chambers, which is what fills with heart, and those chambers are broken into the right side of our heart and the left side of our heart. So what happens is the blood that comes from our body tissues, which is in a deoxygenated state, gets pumped into the right side of our heart and then gets pumped up into the lungs to get reoxygenated. And then once it's reoxygenated, it comes back in through the left side of the heart to get pumped into the rest of our body to give the oxygen and the nutrients to all of the different body parts so they can function properly. So we've actually got 2 different pumps operating within the heart, the right side and the left side, which work together simultaneously. So the function of the heart is to take the blood from the heart, pump the blood from the heart to all of the different organs and body parts of the body, supplying them with the oxygens and the nutrients that's required. But just like your organs in your body require oxygen and nutrients, so too does that muscular tissue that's in your heart. And so for that reason, we have an intricate coronary artery system that is solely responsible for supplying the blood to the muscle tissue. And this is the system that I work on in my laboratory. So in the clinic, we can use an angiogram to actually look at how well the blood is flowing through the coronary heart, through the coronary system, supplying blood to the heart. So here we see beautiful blood flow extending all the way to the bottom of the ventricles. But in this example, we can actually see the classic example of coronary artery disease, which is caused by the disease atherosclerosis. And we can see that there's quite a severe blockage in this coronary artery, which is stopping the blood from getting to the bottom of the heart. Once that stenosis or that blockage is fixed up, then the blood is now getting to the bottom of the heart and we're seeing the blood flow restored. So the disease that's causing this blockage is a disease called atherosclerosis. And shown here is an artery that's been taken out of a person post-mortem, and it shows us exactly what this disease looks like inside our artery. So we have this fatty material that gets deposited in our coronary arteries due to the elevated levels of cholesterol in our blood. And then overlaying that fatty material is this thin fibrous cap. So this lesion itself can grow large enough to block the blood flow through our coronary artery, or else this thin cap can actually rupture, and in rupturing it causes the formation of a clot or a thrombus to form. And this thrombus then is what actually blocks the coronary artery. And the consequences of this is that a person will have a heart attack called a myocardial infarction, or if this clot forms in the carotid artery, this can travel up into the brain and block artery within the brain, thereby causing a person to have a stroke. So this disease, atherosclerosis or coronary artery disease, is the major cause of death in Western societies. So in the USA, coronary artery disease or cardiovascular disease is responsible for 32% of all deaths. So that's 1 in 3 people are dying from heart disease. And heart disease has been the major cause of deaths in the USA every year since the 1900s, except for the year 1918 when the deaths from war took over from the deaths from coronary heart disease. So if you were to work out the statistics for this, in the USA, coronary heart disease is taking the life of a person every 40 seconds. And the reason that I'm so passionate about studying heart disease is statistics tell us if we can eradicate all forms of heart disease from our society, our own life expectancies would be expected to rise by about 7 years. So I want to put this into perspective for you. So heart disease is the #1 cause of deaths in our society. So if we were to add up all of the different cancers, all of the different types of cancers and all the deaths from all of those different cancers, we can see that the number of deaths from all of the different cancers added together is actually less than the deaths caused from cardiovascular disease. Now, this is true for men, and this has been known for a long time. Heart disease is a disease for men, but we can see here in the data shown in pink, indicating for the number of deaths in women, that heart disease is also a major problem for women. So in no way am I going to belittle the impact that breast cancer has on women in our society. It's a devastating disease, and there's no denying that. But if we want to put it into perspective of heart disease, over recent years, breast cancer has caused the deaths of 1 in 30 deaths, whereas coronary heart disease has caused 1 in 7 deaths. And just here in New Zealand, 48 women die from cardiovascular disease every week. So the reason that we all know that breast cancer has such a huge impact on women in our society is because of the great fundraising campaign out there, the Pink Ribbon campaign. It's in all our sports. We see cycling shirts with the pink ribbon. The cricket players, the football players are all out there promoting pink ribbon and breast cancer research. Whereas the campaign for heart disease in women is less out there in the public arena. So all the data that I've shown you thus far is data from the USA. So you think, okay, well, here in New Zealand or in my home country, Australia, we're safe. So I'm just going to show you some local data. First of all, the all-black data, which is representing the New Zealand data. And we can see that the actual statistics for New Zealand is very similar to what we see for the USA. So the USA is the data in blue, and in black is the data from New Zealand. So again, we're seeing rates of 1 in 3 deaths in New Zealand males is due to heart disease, and in females around the 20% rate in the New Zealand women. For my home country, Australia, we see that the rates are very similar to what we see for the USA and also for New Zealand. But I want to draw your attention to the stroke rates, so the deaths from stroke in females in New Zealand and in Australia. And actually, our two nations are doing worse than the USA in terms of keeping women alive after they suffer a stroke. So for the next few slides, I'm just going to show you Australian data because we've, in Australia, the latest cardiovascular statistics have just been released in 2013. But it's okay for me to show you Australian data because New Zealand often follows Australia, as I can show you here in my favourite sport, Ironman triathlon, where we see the Craig Alexander, the Australian Craig Alexander, who was world champion at this time. This is the 2011 Ironman Melbourne race, and he's just in front of the New Zealander, Cameron Brown. Craig Alexander went on to win the race, and Cameron Brown was a close second. And this is me finishing the race quite a few hours after these pro men. So the first thing I want to tell you is in Australia and also in New Zealand, the news is not all bad. So for my entire lifetime, the death rates from cardiovascular disease have been falling. And this is true for both men and for women. And one of the major impacts on decreasing the death rates from cardiovascular disease has been a huge amount of research that's gone into improving the surgical interventions that we can now perform, as well as the pharmacological agents that we can now use to treat the disease. So shown here, we can see that over the last 10 to 15 years, there's been an increase in the number of procedures that have been performed in the Australian hospitals. This is true for males and to some extent for females. So one of the procedures that can be routinely performed now is that of a stent placement. So here we can see a blockage in the coronary artery. And this blockage, what we do is we use a catheter, and we use a catheter to insert what's called a balloon stent in the area which is being blocked. And then once it's in the right area, we inflate the balloon, and this basically forces the stent and the balloon to open and actually open up that blocked coronary artery. The balloon is then removed, and the stent stays in place and remains as a scaffolding holding open that artery for hopefully for the remainder of your life. The other procedure that can be used is that that is done in the hospitals these days is a coronary artery bypass. Now this is a little bit more invasive, and it is usually done when there's multivessel disease. So here we can see there's a stenosis in a number of the different coronary arteries. And basically what the doctors do, the surgeons do, is they go in and they replace the blocked arteries with arteries from other parts of your body. So they'll take the mammary artery, or they'll take some veins out of the body from another part of your body, and they'll use these and basically reconstruct a coronary artery system for you so that blood can get back from your aorta back to the myocardium of your heart and restore blood flow. So in conjunction with the increase in surgical interventions that's being used, we've got an improvement in the pharmacological agents that can now be used to treat patients. So we've had a huge increase in the number and also the usage of drugs that are targeted to preventing clots from forming. We also have an increase in the drugs that are available to lower our blood pressure, and also there's been a huge increase in the use of statins to decrease cholesterol levels. So decreasing cholesterol levels is something that has been pushed into the public arena for many years now. And not only are we relying on our doctors to give us statins and drug treatment, but there's also these huge campaigns for us to try and change our lifestyle so that we can lower our cholesterol levels and live healthier lives. And one of the best lifestyle campaigns that's out there at the moment is the one that's being pushed by the American Heart Association, and it's called Life Simple 7. So in Life Simple 7, they're asking us to go and get active, and by getting active, they're asking you to do 150 minutes of exercise per week. They're telling us to control our cholesterol levels, telling us to eat better, to manage our blood pressure, to lose some weight, reduce blood sugar, and hopefully to stop smoking. But unfortunately, while the surgical interventions have improved and our drug therapies have improved, as a society, we're not doing very well in maintaining this healthy life campaign. So once again, this is recent data that's come out of the USA, and it's actually going through those Simple 7 and how well the US adult population are doing in managing each of these 7 steps. So if we look at smoking, it's actually good. We're down to 76% of people are no longer smoking, or 76% of people do not smoke. But when we look at body mass index, we can see here that 66% or more are either obese or overweight. If we look at physical activity, only 40% of the adult population in the USA are getting adequate physical activity on a weekly basis. More than 50% have high blood cholesterol levels, more than 50% have high blood pressure levels, and about 40% have high fasting blood glucose levels. But this is the statistic that's probably most alarming, and that is only 0.3% of the US population that was surveyed are actually maintaining their healthy diet or meeting the criteria to get a good healthy diet score. And if you have a look, and it's actually close to 80% actually completely failed the healthy diet score. So what this is doing is actually setting up these adults to begin to get the diseases, coronary artery disease, atherosclerosis, as well as type 2 diabetes. And that leveling off that we saw in the decrease in cardiovascular rates over my lifetime might start to level up, and we might actually start to see a U-turn where adults are getting more coronary artery disease because of this lifestyle impact, the impact that this lifestyle will have. So this is the adult population. So what I'm going to show you now is even more scary. And this is the data from the US children surveyed at the same time as for the adults. So it's good that only 85% of them are not smoking. But what is not good is that 35%, so 1 in 3, over 1 in 3 US children are either overweight or obese. Only 36% of them are getting adequate physical activity. And when we look at this statistic, we're seeing that 30% of our children, like children in the USA, have high cholesterol levels. This is children that we're talking about. 15% have high blood pressure and 15% have high fasting glucose levels. And not one child that was surveyed, or not one family that was surveyed, met the healthy diet criteria score. So this is alarming because these children are looking at getting early life coronary artery disease, type 2 diabetes. And just in my lifetime of working in a clinic, so as Professor Craig pointed out, I began my postdoctoral years in a diabetes clinic. And in a diabetes clinic, 15 years ago, it was really rare to see a child with type 2 diabetes, and even more rare to see a teenager with the fatty streaks of atherosclerosis. Now in the clinic, this is becoming more and more common, where we're diagnosing children and teenagers with type 2 diabetes. So this is an issue because these children will go on to get early life atherosclerosis. So what I try and do is actually try and get out into the society and into the community, and I talk to teenage children and the parents of teenage children or the parents of children. I target P&C communities in schools and try and just talk to them about what it is to maintain a healthy lifestyle balance. So what I do is use my passion for sports, and I do ultra marathons and Ironman triathlons, and I use this to actually get in front of people and say it is actually possible to maintain a healthy lifestyle balance and be successful in a career and raise children and do everything. And actually, if you're healthy, it's actually easier for you to be successful at everything that you do. So it's been pleasing for me that in some instances I've actually been able to encourage high school children and mothers of high school children to participate in local fun runs. And often when I'm running now, I'll actually see them out running, and it's nice to know that I'm having that impact, even if it's just a small impact, on trying to promote a healthy diet in our teenage children. So when I go out into the community and talk about lifestyle balance, I don't go out there and say, okay guys, you've got to sign up and do a marathon, or you've got to do an Ironman triathlon, because only crazy people do that, I'm told. But instead, I talk to them about, well, how much energy-dense foods are you putting into your body every day compared to how much activity are you actually participating in? And one of the things I like to show is this slide. So for an average teenager to grab a Mars bar and a Coke as a snack, this is just a common occurrence. But if you were to do that, you're actually taking enough energy in your body that you could then go running for an hour and 15 minutes non-stop to burn off all that energy that you've just taken in. If instead you were to have a chocolate chip muffin and a chocolate latte, you could actually go running for the next hour and a half to 2 hours to burn off the energy that you've just taken into your body. By comparison, if you choose a less energy-dense food, like your apples or your oranges, just something that's a bit more natural, walking from lecture to lecture is actually burning off the energy that you've just consumed. So this is what I mean by an energy-dense food. And why is that? Because if you consume a can of Coke, you're basically taking in 10 cubes of sugar. And if I was to sit here and offer you 10 cubes of sugar, most of you would say, no way, I'm not going to take in 10 cubes of sugar. But most people would drink a can of Coke quite readily. You couple that with your Mars bar, you're then taking in another 7 teaspoons of sugar and 3 teaspoons of fat. So putting that all together, that's too much energy, even for me when I'm in my peak training for an Ironman. It's too much energy for my body to absorb and to consume. And so that glucose that I've taken in, that sugar I've taken in, gets converted into triglyceride, and triglyceride then gets stored in your body as fat or your adipose tissue. And this is why we're seeing a rise in our obesity rates in children and teenagers, is simply because of this overconsumption of energy-dense foods. So what we need to happen is that the community to embrace the healthy living changes, and just step by step. And at the same time, we need more research into heart disease so that we can actually stop the disease from occurring in the first place. And so one of the initiatives that I've been involved in heart disease research over 15 years or 20 years now is trying to understand the difference in heart disease that presents between men and women. So if we look at this statistics, so this is a statistics for prevalence of heart disease, not death rates, but prevalence of heart disease. We can actually see that men are more likely to get heart disease, and it's more prevalent in men than it is in females, especially in these younger years. So in a man that's 45 to 54, he's 2 times more likely to have coronary artery disease than a female. However, the females catch up in later years. Now, while men are more prone to getting heart disease, when females get the disease, it's more likely that they'll die from the disease. So since 1984, the mortality rates for women have actually been higher than men in the USA. So men are more likely to get the disease, but when women actually get it, it's more likely that they're going to die from it. So a lot of research now has gone into trying to understand, well, why do men get more heart disease in the first place? And then why is it more likely that the female will have a myocardial infarction or a stroke and die versus a man? And one of the key advances in atherosclerosis research is our ability now to image the disease in real time. So shown in the background is that image that I showed you previously, which is actually an artery that's been taken out post-mortem, and we can actually see the disease. But now we can actually use specialized cameras that we are able to insert into the coronary arteries of people while they're still alive and actually look at how much atherosclerosis they have. And if we look here, this is an indication of a plaque in a coronary artery. And this is the thin fibrous cap. The bit that's shining bright yellow is the thin fibrous cap. And this dark material here is the lipid core, this fatty material that's shown here. So we can actually visualize that this is quite a large plaque that's sitting in someone's coronary artery. We can see that the lumen should be round like a pipe, and instead it's this oval shape because the lesion is encroaching on the lumen. And then in this image, what we see is that thin fibrous plaque is actually ruptured, and we see a breakage in that thin fibrous cap, and now what we see is the formation of a thrombus. And it's that thrombus that can travel down through that coronary artery network, cause a blockage, and cause someone to have a heart attack. So this is another image just showing you this complete rupture of that thin fibrous cap. So we've been able to visualize these rupture type of atherosclerotic plaques. But then as this research developed, what we were able to now show is that atherosclerosis doesn't always present as that classical thin fibrous cap, rupture, cause a thrombus, people have a heart attack. But instead, there's actually another form of atherosclerosis that's quite prominent in coronary arteries in about 30% of cases. And what we're seeing here is a much thicker yellow layer, so a much thicker fibrous cap, and a much smaller lipid core. But in these kind of lesions, they still go on to form myocardial infarctions and strokes. We actually get erosion of that fibrous cap and the formation of smaller clots. And so these clots travel down into smaller coronary arteries, thereby causing the myocardial infarction or the heart attack, or they can travel up into the brain and cause a stroke. So when we start to think about gender, what we now know is that in women develop the disease later. So men are developing at 45 to 54, whereas women are developing it after the 55 and then older. And we know that they have, now from these imaging analyses, we know that they have predisposition to get these more erosive plaques rather than these rupture plaques. So younger women are more likely to have an erosive plaque, whereas a younger man is much more likely to have a rupture type of plaque. And then because of these erosive type of plaques and the smaller clots that form in women and then the smaller coronary arteries that get blocked, it actually turns out that they have less obvious symptoms of having a heart attack. So a woman might present at an ER suffering a heart attack, but because the smaller coronary arteries are being blocked, it's not actually as painful or as symptomatic as what we see in the rupture kind of plaques that a man is more likely to present with, who have that obvious heart attack that is depicted in Hollywood movies. Now, because of this different type of disease that seems to be associated with women versus men, there's been a hypothesis for a number of years now where our sex hormones are responsible for this different type of disease between the sexes. So in females, our sex hormones are estrogens, while in men, the sex hormones are androgens. Now, it's thought that estrogens, because women are developing the disease later, that estrogens are actually protecting women against developing earlier life atherosclerosis or coronary heart disease, whereas androgens the male hormones are thought to be promoting the disease in men, which is why they're getting the earlier onset disease. So we actually studied this arm in my laboratory for a number of years, and to simplify it in just one slide, I'm going to show you some data that we got from an animal model. So here we've got normal mice. These are normal male mice, and they develop atherosclerosis. And we can see in that circled area, we can see a small amount of plaque, very, very small amount of atherosclerotic plaque. In mice that have been modified so that they are no longer able to produce their own testosterone at all, so these male mice have no male androgens, we can see that there's much more plaque present in these coronary arteries. Now, if we take these mice that can't produce their own testosterone and then treat them with testosterone, so we give them a testosterone implant so the testosterone is restored, we actually then reduce the amount of plaque that they're getting. So in fact, what we were able to show in the laboratory is that male hormones are not driving atherosclerosis in men or coronary artery disease in men, and androgens are very unlikely to be the reason that men are getting that earlier onset atherosclerosis. And this is backed up by epidemiological data. So if we take men across the spectrum, and we've got men that have naturally occurring low testosterone levels and naturally occurring high testosterone levels, it's actually the men that have low testosterone levels that have higher levels of coronary artery disease. So it seems like low testosterone is associated with heart disease rather than high testosterone promoting heart disease. So that whole androgens driving atherosclerosis, we were able to shut down that hypothesis. So then we turned our attention to the other hypothesis, well, can estrogens protect females against heart disease? And looking at this epidemiological evidence, this is just showing you the same thing I've been showing you, that men get heart disease earlier than women do, but I've just shown you in a slightly different way. So I can point out that as women go through menopause, heart disease increases. So during menopause, a woman's ovaries shut down and they're no longer able to secrete any estrogen. They no longer secrete estrogens, and their estrogen levels fall dramatically. And so it would expect, so during this time when estrogen levels have fallen, suddenly heart disease takes off. So women have lost their estrogen protection. So is this what's driving the heart disease in older women, but also what's protecting the women against heart disease in their earlier life? And there's been a huge amount of data to support this estrogen protection hypothesis. So estrogens have been shown to reduce inflammation in the heart. It evokes good genomic changes in the heart. It decreases cellular stress. And in animal models, it's been shown to decrease atherosclerosis. It has a good effect on ischemic disease, and it protects against heart failure. So there's a lot of evidence to suggest that estrogens in younger women are protecting against heart disease. So then it was thought, great, if estrogens are going to protect women against heart disease, why don't we treat postmenopausal women, so these women that have lost their ability to produce their own estrogens, with estrogen replacement therapy? So a whole lot of hormone replacement therapy trials were started, and to see if estrogen given to women after they've been through menopause and they've got this rapid onset coronary artery disease developing, will it actually slow down the disease in these older women? But what was found was actually the opposite, or actually it was quite dramatic. So hormone replacement therapy in older women, not only in some studies showed no cardiovascular benefit, in quite a number of studies it actually promoted cardiovascular events. And a lot of these studies were actually stopped prematurely because of the adverse effects of the hormone replacement therapy. And so what we did in the laboratory is we actually had a look. If females already have atherosclerosis and then they're given estradiol on an estradiol null background, so they've lost their own ability to produce estrogens, and then we give them back estrogens after they've already developed coronary artery disease or atherosclerosis, what do their plaques look like? And what we found was that in the females that were treated with estradiol, we're actually seeing this dramatic increase in the calcification of that atherosclerotic plaque. So atherosclerotic plaque has an important clinical consequence. It hardens the artery, it hardens the plaque, and so it's much more likely to rupture and cause a clot. And that's exactly what the people that was running these hormone replacement trials were seeing, that these women were getting more clots and having more strokes and having more myocardial infarctions. So the data that we were able to show in the laboratory backed up what they were actually observing in these clinical trials. And so now what is known is that women have this high mortality rate, but men are getting the disease 10 years earlier. We know that women tend to have more erosive plaques versus the rupture type of plaques that we see in men. And because of that, women tend to present with different heart attacks, different heart attack symptoms, but also we also now know that hormone replacement therapy is not really a valid option for treating older women against heart disease. In men, they have the classical heart attack symptoms, but moreover, a lot of the surgical interventions and the drugs that we now have for treating heart disease are working very effectively for men because we're seeing that decrease in mortality rate. So we still have this question of why men are getting the heart disease earlier, and is it because it's protecting, estrogens are protecting the females, and that's probably a very likely scenario. But then once the females get the heart disease, we still don't understand why there's such a high mortality rate. And one of the reasons for this is really there's been a lack of research in the last 20 years on women-specific disease. Only in the last 10 or so years has it become really obvious that the disease in women looks and appears to be different to what it is in men. And if we look at all of the studies that have been done in the last 20 years, we can see most of the studies have concentrated on men. And the data that they've got in terms of interventions, in terms of surgical interventions or drug interventions, have all basically used men as their cohort rather than women. And there's very few, there's much less data available for treating the disease in women. And that's something that I will be concentrating on here in Otago, is working on this balance between the data for men versus the data for women. And we'll be studying why women are getting this higher mortality rate. So I've not got to where I am today without a strong team behind me. And this includes my mentors, Professor David Sellenmeyer, who's a cardiologist at the first hospital that I worked at, the Royal Prince Alfred Hospital in Sydney, and he taught me all about hearts. Professor David Handelsman has been responsible for teaching me all about sex hormones. And then Professors John Turtle and Phil Barter. Phil Barter was the director of the Heart Research Institute my entire time that I was there. They've both been instrumental in having a positive influence on my career. To my PhD supervisor, Tom Ferenczi, although I left the field of microbiology and became very interested in diabetes, and one of the reasons for that is that during my first pregnancy I got gestational diabetes, and so it became a human factor for me, so I wanted to study it, and that was really the major reason for my shift from microbiology to diabetes, and I haven't looked back since. No person can stand up here as a professor and not be thankful for all of the people that have actually worked in the laboratory. I've had a number of talented postdocs go through my laboratory over the years, but a special thanks has to go to Dr. Christine McGraw, who has been a foundation in my laboratory for 15 years. And it was really pleasing that when I made the decision to take up the appointment here at the University of Otago, they've since made her an appointment to promote her to a lecturing position from a Vice-Chancellor's Fellow to a lecturing position, giving her now the opportunity to embark on her own independent science career. And I think it's really nice that people that we train go on to have their own independent careers down the track. I've had a lot of students go through the laboratory. There's too many to mention, but all have contributed to the research output in my lab. And I think while being a scientist and working in laboratory is very hard work, we also have a lot of fun. So I have postdocs come from China, as shown here, and I actually grew up in the south coast of New South Wales in farm country. So it's really nice to be able to take these people back to where I grew up and show them around. We go to international conferences and present our work. We have graduations go through the laboratory, and we've also had a number of awards. And we've also had a number of babies born in the laboratory, and I'm proud to say that I'm the godmother to 2 of the children that have been born in the lab during my time. So being successful at science and forging a university career takes a lot of time and dedication. So I'm very fortunate that in my journey I have been supported by my 2 daughters, Jamie and Regan. From a very early age, these 2 girls had to learn to be independent because Mum wasn't always there to make their lunches or help with their homework or be at soccer or dancing events. So this honour tonight I share with them. We, as you can see, have all grown up together, and I hope that what I do inspires them to dream big and to follow their own ambitions in whatever they decide to do. So my oldest daughter is now 19 and my younger daughter is here tonight, 13. Thank you.
Thank you, Alison, for the presentation. I'm Brian Hyland, the Head of Department of Physiology, and my job is to do the vote of thanks for Alison's talk. So clearly, we've come a long way since the Greeks believed that the heart was the seat of the will and the soul, and that the brain was just an organ for dissipating excess heat. And clearly, of course, now we have a different understanding, but the heart is still the heart, and without the heart, nothing else works, which I think Alison has done a very good job of illustrating for us tonight. Now, she's also highlighted, the horrific statistics of what heart disease is doing to us. And while you can argue, well, we all have to die of something, the problem with heart disease is that when it strikes people down. So it's striking people at a point in their lives when they still have much to give. So it's a terrible tragedy, of course, for the families, for the individuals themselves, of course. But it's also taking away from our society people at a stage where they're ready to not only continue contributing to society, but to pass down their knowledge and their experience to the younger generations. So the numbers, the financial implications to the country are a terrific impact, and I think Alison's done a wonderful job of highlighting that importance. And although she showed graphs that indicated that the rates were dropping, it's been worse in the past, but it's still a terrible problem for us. And I think another thing that Alison did a great job of highlighting was the need, 2 things really, the need for basic research, sometimes in animal models, that enables us to address key functional mechanistic questions that then translate through into the clinic and improve the treatment that we can provide to patients. And I think the final thing, and reflected in the title of her presentation, was the scandalous lack of studies across the genders for this particular disorder. And it's not just heart disease, I have to say. It's a widespread problem that we are so badly lacking in data about 1/2 of the human population. So we're looking forward very much to having Alison pursue that research here and push that frontier forward in her time at Otago. Now, it's traditional in this, my role also is to pass on a token of our appreciation to Alison for her presentation, but as it was pointed out by Pat earlier, you know, Alison has only just joined us, so it's also my chance really to personally welcome her not only to the Professoriate, which is the main role of this event, but also to the department and to the university, and to wish her all the best for a very fruitful and enjoyable future with us here at Otago. So I'd just like to make a small presentation. I have to put the microphone down because I don't have so many hands, and then I'll pass on to the Pro-Vice-Chancellor, Health Sciences, Peter Frampton, to finish off proceedings. So Alison, we have two things here for you, something to remember the presentation by, and something perhaps to offer some intellectual stimulation from our local university bookshop.